I have your test, Jesse.
Hello. Pardon?
I have your test.
Okay.
Yeah, you won't be back. So, well, just pick it up when you get back then.
Okay, thank you. Sorry, I'm getting up.
When do you guys play?
We play tomorrow.
Okay.
We practice today though.
Okay. How's the weather?
It's lovely.
Rub it in.
Sorry.
Yeah, it was 16 degrees this morning. And it was probably a lot colder last night, but supposed to get up to 40. So yeah, anything above 30, and I'm liking that. So I'm going to pass some more of these back. So we'll start in about 4 minutes.
Okay.
Not here. Not here. There you go, Amanda. It's respectable. Jacob, did you already pick yours up? That's why, yeah. Any of yours too. Okay, that's why. I'm looking for it, and I can't find it. Okay. So Josh, hopefully Josh will be here. Oh, there he is. And then Ben sits next to you, so. Yep. And somebody needs to work on their test anxiety. Okay, that's on you, brother. Okay. Kelsey's not here. Hope. Kelsey's. Jesse's Kelsey with you?
Yes, she is. She's getting on Zoom now.
Oh, okay. Okay. Oh, okay. So Sarah, oh. So Sarah, you're gone too.
Hi, Professor.
Sarah, I have your test, so just pick it up when you get back.
Okay, sounds good.
And Katie, same thing. I have your test. Just pick it up when you get back.
Sounds good. Thank you.
It's not here. Oh. I'm hoping Emily comes. Oh, she's okay. So, is Chapman here today? Do you have class with them?
Not today.
Not today. Okay. Good. Because if they don't come, then you could give it to them, but
I would.
that's risky. So, and JP, where's JP? He already left. Okay. All right. All right. Okay, gang. We're going to get started. We have several of your compatriots on Zoom. And most of the ones on Zoom are members of our athletic teams. So there they are. Everyone say hi to them. Oh, that was an anemic hello. Let's have a real hello. Thank you. And let's wish them well as they compete for our school. They are essentially representatives of Spring Arbor in the greater world. So we thank you guys for representing us elsewhere. I know you're suffering for the Lord in sunny Florida there, but yes, that was a dig. So all the best to you guys, and we hope you guys stay safe, but play hard and play well. So without further ado, then let's go ahead and let's see, get to what we're going to talk about today. And those of you on Zoom, let me remind you, if you have a question and you send it to me by text, by chat function, there's a really good chance I won't see it because I don't tend to see chats come up during lectures. So just say something. Hopefully I'll hear it in the speaker. Otherwise, I just won't hear you. So that's just the long and the short of it. Connor, I have your test up here. So you can pick this up after class, okay? Or if you want to come and get it now, it's right here. Okay, what about the exam? The exam as a whole went better than I thought it would go. Usually the first exam is the worst in this class. And with the curve, the class in general didn't do all that shabbily. So I think you guys are to be congratulated. And for some of you, didn't go quite as well as you would have wished. So there'll be other tests. They, excuse me, won't be as abstract. The principles won't be as abstract as this. So you'll have a chance to do a bit better. It'll be more drugs and things like that rather than basic principles and what have you. So if you're kind of underneath the spinach with this test, be encouraged. There's chances to get that grade back up. If you did well, then you know what formula to use. And I recommended this at the beginning of the semester. I'll continue to recommend it. Studying in groups can help you identify your shortcomings, especially the ones you don't know are there. So if you don't have a study group, make one, find one, and that should help your studying. If not, then let's find some other way to help you study. Are there any questions about the exam, about the curve, about grades, about anything? We still have one person who hasn't taken the exam. She'll take it today. And then after she takes it, I'll post the answers. And I'll put the answers on Blackboard. So I will post the answers, just not yet. I don't want to give that person who hasn't taken the test the answers. That would not be cool. All right. All right, if there are no questions, then we'll go ahead and hit it. Also remember, I do have office hours today. If you want to come talk to me about the exam, please come to my office hours. If you can't come during then, let's find another time. I'm leaving a little early today because I'm going to go up and see my daughter in Wixom later today. So I won't be here till 6 like I normally am. I'll leave just a touch early. All right. So let's quickly review what goes on in a pacemaker cell. Let's take a little bit of a broader and maybe more detailed view at the electrical physiology. And I've got more colors here to hopefully help me out with this drawing. So let's draw a pacemaker cell. Now, those who've had me before, you've heard me make this disclaimer and this warning. The only class I really did poorly in high school, middle school was art. I suck when it comes to drawing. When I had to do some drawings for class in graduate school, my professor told me, I've been doing this for 30 years. In 30 years, these are the worst drawings I've ever seen. So I really suck at drawing. So if my drawings offend you, get used to it. They've been offending people for years. Okay, these are terrible. I'm just giving you a warning. Don't look at them and say, oh, that's lousy. Of course it's lousy. I know that. That's why I got into this business and not art, because I have no talent for drawing. So let's pretend this is a cardiomyocyte, but it's a pacemaker cardiomyocyte. So this cell has automaticity. Now, those of you on Zoom, you can't see what I'm drawing, but ask somebody to draw it for you, and then they can take a picture of it on their phone and send it to you. All right. Now, we have these pacemaker channels, these hypersensitive to cyclic nucleotide channels, and those are a voltage-gated sodium channel. They open when the cell is hyperpolarized. So let's put those in blue. All right, these are going to let sodium into the cell. That's going to start to depolarize the cell, but as you can see, it depolarizes it slowly. Now these will eventually cause another voltage-gated channel to open, and that channel is the voltage-gated calcium channel, also known as L-type calcium channels. And those are going to now cause the cell, when the cell reaches threshold, these will open and you get this depolarization. These are responsible essentially for the depolarization of the pacemaker cell. Now, this particular phase of the early depolarization here, this is often called phase 4. Phase 4. And so these are the hypersensitivity to cyclic nucleotide channels. You know what? If you want, you can call them pacemaker channels, which They're politically correct channels, PC. So pacemaker channel, PC. That's a little easier to remember than hypersensitive to cyclic nucleotide channels, which makes you want to say Gesundheit when you're done. So if you want to call them PC channels, that's perfectly fine. Because it seems to me that's order of magnitude is easier to remember. Those of you who took the cardiac physiology class, what did you call these? ACN channels, okay. You can call them pacemaker channels because they're called that too. That's what cardiologists would call them, for example. All right, so these are associated with phase 4. So I'm just going to put a little 4 there to remind us they're involved with phase 4. That phase there. And then the L-type calcium channels they're involved with this depolarization. And this, strangely enough, is called phase 0. Phase 0. So phase 0 is about depolarization. So I'm going to put a little 0 here to remind us that has to do with phase 0. Then you get the opening of voltage-gated potassium channels. Voltage-gated potassium channels. Can you even see that? That orange doesn't come out very well. Better than the yellow, trust me. Eh. Okay, you can probably kind of see that. Now with this, potassium is going to leave the cell. Because remember, potassium is high inside the cell. And these are your voltage-gated potassium channels. Those are going to be involved with repolarization. Repolarization. And that repolarization has to do with that, and that's usually called oh darn it, I messed this up. I'm sorry. I think I completely messed this up. Did I mess this up? Yeah, I messed this up. I got the phases wrong. I'm sorry. Got the phases wrong. And this has to do with phase 3. So we're going to put a little 3 here to remind us that's phase 3. This is phase 4. This is phase 0. My bad. So let's fix this. That's 4. That's okay. That's 0. That's 4. Yeah, 0, 4, 3. So there's 3 phases here. That's what's happening here. All right. Now, if you inhibit or slow down these channels, what do you think is going to happen to the electrophysiology of this cell? If you slow down these L-type calcium channels, you block them with a drug. What do you think is going to happen to electrophysiology of that graph? Okay, I see Jessica sitting there going, she's trying to think that that's what you should do. Is the graph going to get pushed this way, or is it going to get pulled out this way? It's going to get pulled out this way because the depolarization is going to be slower. And that is exactly how you treat these arrhythmias of the heart that originate in the SA node. And these are called sinus origin arrhythmias, and very often they simply reside in the fact that the SA node is too active. And you can use a drug that will inhibit this channel and slow it down. So what it does is it stretches out this electrophysiology and it slows the heart down. And there are two drugs in particular that are used for that. And this type of arrhythmia, there's two types of main arrhythmias. There's arrhythmias that originate in the ventricles. They're called ventricular arrhythmias. And then there are those above the ventricle. They're called supraventricular arrhythmias. Those originate in the ventricles and then supra. And of these, there's actually lots of different types of these, but those that are of sinus origin, those can be treated by using a group of drugs called calcium channel blockers. And these calcium channel blockers block these voltage gated calcium channels, these L-type calcium channels, that's their target. And that shows you essentially how you can modify the electrophysiology of these cells using drugs. Now there's another little wrinkle let's throw in here. There's also on this cell surface there's actually a beta-1 adrenergic receptor. This beta-1 adrenergic receptor binds epinephrine if it's available in the bloodstream. It's made by the adrenal glands, the medulla of the adrenal glands, or norepinephrine that comes from sympathetic nerves. So it binds either norepinephrine or epinephrine. Now, when this receptor binds these neurotransmitters, it's going to now send a signal to the inside of the cell because this is a G protein coupled receptor. And this is going to increase intracellular concentrations of cyclic AMP. Cyclic AMP is going to activate protein kinase A, and protein kinase A is going to phosphorylate this channel. Well, when it phosphorylates the HCN channel, because it's hypersensitive to cyclic nucleotides like cyclic AMP, it's now going to let sodium in a lot faster. And now this is going to go from not so steep to pretty steep. So for example, let's say Miss Sarah over here was studying late for her pharmacology exam at the library. And then she walks back to where she lives, Sarah, where do you live? In the apartments. She's walking back to the apartments and she comes face to face with a real actual cougar. Now, what's going to happen to Sarah? She's going to go eek or something like that, right? Now, her heart is going to practically jump out of her chest because she has a fight or flight response. That causes a release of catecholamines from the adrenal glands, which are just above the kidneys. This will cause her heart to beat a lot faster because it's binding this receptor, and that's going to give her energy to run away from the bloody thing or to, I am woman, hear me roar, and beat the thing up. Right there? Darn straight. Okay, so especially if you had your coffee. And that's the other reason you drink coffee in the morning. Caffeine is a adrenergic receptor agonist. And coffee will raise your heartbeat. Ben's looking at me to say, yep, I know about that. Yep. In fact, Ben, you look like you lift. Do you use a pre-workout at all? No? Good man. But if you used a pre-workout, you'll notice most of them have caffeine in them. In fact, some of them have a lot of caffeine in them. What's that stuff GNC sells? What's it called? Yeah, that and Animal Pack. That's got enough caffeine in it to kill an elephant. It's got a bunch of caffeine. That will jack you like nobody's. I mean, you'll have to walk around your car 5 or 6 times. It's awful. It's awful. But essentially, that's why this causes your heart rate to go up. Now, what if you blocked this receptor? Would that slow down your heart? Yeah, it would. And there's a group of drugs that block this receptor. They're called beta blockers. Beta blockers. Because they block the beta adrenergic receptor. Then you also have drugs that inhibit the pacemaker channel. They inhibit the pacemaker channel. And therefore, they will slow the heart down in general. And those are used for arrhythmias. Those are called class 1 antiarrhythmics. Class 1 antiarrhythmics they inhibit the sodium channel. So the way to remember these is that if you're first in your class, you get to take a trip to the sea. And the sea is full of salt, major component of which is sodium. So you go to the sea and you block the sodium channels. Okay, it's stupid, but hey, if it helps, it helps. These calcium channel blockers are actually so-called class 4 antiarrhythmics. These are class 2 antiarrhythmics. Well, we're leaving somebody out. Potassium channels. Those are class 3 antiarrhythmics. And to remember these, your third place, you get a trip to the banana farm. And bananas are rich in potassium. And that's what's blocked by your class 3s. And then I have some other really dumb mnemonics to remember the drugs in that class. I will share them with you sometime if you're in the mood for some very bad humor. All right, let's move then on to the others. We kind of talked about that. The arrhythmias that can be caused by, in the ventricular arrhythmias, they can either be so-called arrhythmias of automaticity, What does that mean? That means that some cells in the ventricle now start to assert themselves as beat setters in the heart. And they start to fight with the SA node, and there's a war to see who's going to win. Does that make for a regular heartbeat? No, it doesn't. That is a arrhythmia of automaticity. The second type is called a arrhythmia of re-entry. Re-entry usually is a result of scar tissue in the heart. So the beat, the signal to beat is transmitted through the heart, but then it has to work its way around scar tissue, and the signal might get lost or it might get redirected somewhere, and that causes delays. Those delays can cause arrhythmias, or those delays, depending upon what else is going on with the heart, might actually cause some sort of signal to actually go back up to the atria, depending upon what you have going on. So re-entry can really cause a lot of interesting sort of arrhythmias, some of which are just delays, might be asymptomatic, others of which might be actually quite dangerous. All right, now if we go to the other myocardial cells that are not pacemaker cells, they don't have automaticity. If we were to redraw that electrophysiology, what might that look like? Let's go ahead and try and redraw that, provided these bloody things work. Hey, look, they work. Up. Oh. Oh dear. Okay, mental note, don't use orange. All right, so now let's do a non-pacemaker type of cardiomyocyte. Now with these, how do they get the signal to beat? They get the signal to beat from calcium that comes to them from a cell to which they're attached. So we have another cardiomyocyte here. And then we have this little pup here. What's this pup called? That cell's over here. Then let's draw this other cell in a different color. So this is a gap junction. This is part of the intercalated disc structure that attaches cardiomyocytes. So you're going to get calcium. And this calcium is going to flow into the other cell. That's going to give it the signal to depolarize. And so the electrophysiology of this is different than the electrophysiology of the pacemaker cell. This is going to have 5 different stages rather than the 3 that we saw with the pacemaker cells. I'll come back to this. So, all right, so with this one, the calcium comes in, that will depolarize the cell to threshold, And that will then cause the opening of voltage-gated sodium channels. Voltage-gated sodium channels, and that will depolarize the cell. Now the cell initially is at rest. It's at rest, so it is going to go from rest to depolarization, and the depolarization is phase one. Phase one. The initial depolarization will be to phase zero. So if you think, you put a little line, say here, that's at about threshold, and then say maybe right about there, that's your phase zero. That's the influx of calcium from here. And then you're going to have voltage-gated sodium channels that will open and cause that very steep depolarization that you can see there. Let's put the voltage-gated sodium channels in blue like we did last time. And they are going to let sodium into the cell. That causes the initial depolarization. That initial depolarization, that is going to be phase one. Phase one, that initial depolarization, then it's going to get up to that phase there. You're now going to get calcium channels that open, but those calcium channels will open with the opening of voltage-gated potassium channels. That's the reason why you start to depolarize at first, but then your so-called slow calcium channels will open. Those slow calcium channels are voltage-gated potassium channels, and yes, Virginia, they're L-type calcium channels too. They're L-type calcium channels as well. So let's go ahead and take a look at the electrophysiology here. So these are not HCN channels, these are voltage-gated sodium channels. Voltage-gated sodium channels. So then let's go ahead and draw our L-type calcium channels. We'll get those in green, I think. We'll get those in green again. Now we've got a little war going on because calcium's coming in, but potassium is moving out. I'm not going to use this anymore. Let's do these in black. And now potassium, that's going to move out. Now, eventually, when we get from phase zero to phase one, we then go to phase two. Phase two is a plateau phase. It plateaus because you've got this calcium coming in, potassium going out. That's going to cause a delay. And that delay essentially is going to prevent the depolarization, but eventually these are going to close. These will then be open, and so then you'll get your phase three. Your phase three down to repolarization. Then when we get to resting, That's phase 4. That's phase 4. And then we're ready to do it all over again. Now, let's go back to our friends over here. These also can be activated. Excuse me. They can be also influenced by drugs like that over there. So the class 1 antiarrhythmics, if they are going to inhibit this sodium channel, can you imagine instead of getting a graph like this, you're going to get a graph that's more like this? You slow down the depolarization. Because you slow down depolarization, the heart rate will be slower. And then if you inhibit potassium channels, you're going to essentially take this and pull this way. And that's going to slow the heart down as well. And what have you. That's something I'd like you to think about as we talk about these different drugs. Go to these graphs and try redrawing these graphs, seeing how these graphs will change. If you can do that, you'll probably be able to predict not only what they'll do to the heart, and then also what types of arrhythmias these things might be able to treat effectively. Okay, and I said I'd go back to this, so I will. Remember that in heart cells, this is not the case in skeletal muscle, but in heart cells, we have this calcium-induced calcium release. So the uptake of calcium by the cell, the uptake by these voltage-gated calcium channels, that's going to cause internal release of calcium stores. Calcium is required for the contraction of the heart muscle. And that contraction of the heart muscle only occurs when calcium combined to the troponin complexes, moving tropomyosin off the actin, allowing actin to interact with myosin. That's why calcium essentially signals to the cell to release its internal calcium stores. This pump here, this is called the CERCA, C-E-R-C-A, smooth endoplasmic reticulum calcium pump, CERCA pump. This is a ATPase linked pump. It's very powerful, works very quickly to clear the cytosol of calcium. That's why the cell can relax after it contracts so quickly. What's not shown on here is there's also a sodium calcium exchanger. Sodium calcium exchanger, and that sodium calcium exchanger can exchange sodium for calcium, and that can actually increase the amount of calcium in the cell, or it can be used to move calcium out of the cell as well. That's going to be important when we talk about a drug called digoxin and how it works to actually increase the force of contraction of the heart. And this overlays essentially the contraction and the relaxation part. You could see that once you clear phase 2, phase 3 essentially is all about relaxation, and of course phase 4 as well. So 3 and 4 are about relaxation, and then when you're going from 0 to 1 to 2, that essentially is all about the contraction of the cardiomyocyte. And this cartoon here simply is meant to hammer home the fact that it's the calcium coming into the cell via the L-type calcium channel. That's essentially what is going to provide the signal to release your internal calcium stores. There is a protein called phospholambin that actually will tell the CERCA when to work, and phospholambin is also controlled by phosphorylation. And there's our exchanger there that we were talking about. There's also a pump that will kick calcium out of the cell. If it doesn't get into the smooth ER, it gets moved from the cell by this ATP-linked calcium pump. That's the reason why the resting cell has very low internal calcium concentrations in the cytosol. All the calcium stored in the smoothie arm, or it's outside the cell. You need to have that because large amounts of calcium can get precipitated out because there's a lot of phosphate in the cell. To keep calcium concentrations low. And the cell, as you can see, will go through a lot of energy to make sure that happens. Now, so here we have the conducting tissues of the heart. So the SA node, that's the pacemaker of the cell. It's up high in the right atrium. When the signal to beat is established in these cells, it will spread across the atria, pretty much just by virtue of the fact that they're connected. You do have some conducting tissue. There's some tissue in the walls. They're called the Bachmann bundles, the Bachmann bundles. That's why damage to the upper atria, upper wall of the atria can actually slow down, transition across these because you damage the Bachmann bundles. Does it obliterate it? No. No, but it can slow it down. Once you get this beat that's propagated across the atria, it gets to the base here, to the atrioventricular node. Now, do you want the atria and the ventricles to contract at the same time? No, gotcha. You were the first one to vigorously shake her head. Why not? Exactly right. You want the blood to flow from the atria to the ventricle. If you're contracting both at the same time, you defeat the purpose. So there's a delay when you get from the atria to the AV node. There's a slight delay in order to let the ventricles fill. In order to let the ventricles fill, there's a delay of about 200 milliseconds. Ish. Let me qualify that. The delay should be no greater than 200 milliseconds. There's actually a range depending on how fast your heart is beating. Oh, these bloody things. And that's going to determine essentially how fast the delay is. But so usually it's no greater than 200 milliseconds. From the AV node, we go down very quickly to the bundle of His, not his, His. And if you want a really dumb way to remember this is a head of a snake. And so this is Sir His, because the snake goes His. So it's a bundle of His. So that's my dumb way to remember it. If it helps, then please use it. If not, then discard it and find something more mature. Then this breaks into the right and the left bundle branches, which then swing around the apex into the walls and the papillary muscles, and those are called Purkinje fibers. Purkinje fibers, and they're right here shown, Purkinje fibers there. So the AV node is the only connection between the atria and the ventricles. Because remember, there's that fibrous skeleton between the atria and the ventricles. So if there's damage to the AV node, if the AV node goes rogue, then the ventricles are going to essentially pay the price, if you will. So the conduction from action potentials from the SA node are quite fast, as you can see. You get a time delay then as it goes through the AV node. So you get a little slower conduction, and then it increases substantially in the bundle of His and in the Purkinje fibers. Therefore, the ventricles will contract 1/10 to 2/10 of a second. After the contraction of the atria, the right and the left ventricle will contract just 1/10 of a second apart from each other. That's hence the 0.1 to 0.2 seconds. And it's that depolarization that will open the voltage-gated calcium channels that will lead to the stimulation of these other channels, and that will cause the contractile story with troponin and what have you, and actinomyosin, and that's how you get contraction, coupled essentially to excitation. So the action potential will last 250 milliseconds or something like that. There's a refractory period during which you cannot reactivate this cardiomyocyte. There's a relative refractory period during which, if your heart's beating faster, you can cheat this essentially and shove this essentially in this direction. But during that refractory period, the cardiomyocyte essentially is in the process of contracting. Because it's in the process of contracting, you can't activate it to contract again. This is a reason why these really, really fast heart rates can be so inimical to the heart. Also, when the heart fills, when the heart relaxes during diastole, that's the time when the coronary arteries actually open and allow blood flow. So that's the time during when the heart actually gets fed oxygen and what have you. Very good. Now, this electrical activity can be detected by using electrodes over the skin, because the electrochemical activity of the heart will produce some current on the skin. And if you put an electrode on the skin, you can detect the electrochemical potential of the heart, and just like you can with skeletal muscles. And this is the whole principle behind a electrocardiogram, ECG or EKG. And there's one lead, and there's the gold standard, of course, is a 12 lead. But essentially, if you just do a one lead, you'll get a ECG that has these various parts. We go over these various parts, you'll see essentially what each of them means. Now, there's a whole class on how to put the leads on, what the leads are for, and what have you. So classically, your kind of ground leads will be on the leg, the arm, but you can actually put these leads here and here and here and here. And those leads essentially provide your proper grounds. And then you have the leads that go over the heart itself. And you essentially go from the top. You start feeling the spaces in between the lungs. When you get to number 4, essentially you put the first lead on the right side, and then the other leads essentially go from here, and then 2, 3, 4, 5, 6, and what have you. That takes practice, but if with a little bit of practice, finding that if you get some guy with a really, Arnold Schwarzenegger chest, it can be really hard to find it, but you just have to push harder. And if they whine and say, oh, just say, oh, shut up, you big baby. And just kick it. In fact, you could feel it yourself. So you can feel the top of the clavicle get so down. You can feel that. It's not hard. And then 2, and then 3. Ooh, ow. 4. You have to do 4 right there, 4. And then 1, 2, 3, 4, 5, 6, and so on and so forth. It just takes some practice. Research has shown the people who are at the worst at doing this are actually cardiologists. Because cardiologists did it once and then they never practice it, because the EKG tech does it. They just interpret the EKG, so they're not used to putting leads on anymore. So they're unpracticed, so they suck at it. Okay, P wave. That's first little blip on the ECG. P wave is caused by atrial depolarization. Atrial depolarization. The atrial depolarization is not that robust. The atrial repolarization is very wimpy. You virtually never see it. There are pathological conditions under which you can see it, but normally you'll never see it. So atrial repolarization, that's the P wave. After the P wave, you have the large QRS complex that's caused by ventricular depolarization. Ventricular depolarization. This is very robust. And after that, you get the T wave, that is ventricular repolarization. Ventricular repolarization. Now, from the P wave to the crest of QRS, the PR interval, that's the interval that represents the delay at the AV node. That interval represents the time you're waiting to let the ventricles fill, and it should be no greater than 200 milliseconds. So if you get a stretched PR interval, just give me a guess. What do you think that tells you? Right, or the signal that's supposed to go from the top of the heart to the bottom of the heart is getting lost, or it's got roadblocks it has to work its way around, or something like that. There's something wrong with conduction. There's something wrong with conduction. That's probably what that means. Now, a delay like that might be completely asymptomatic, but it might not. It depends on the severity of it. And if we overlay the pressure graph with the heart sounds and the EKG, notice the first heart sound comes at the bottom of the QRS wave. At the bottom of the QRS wave, that essentially is lub, S1. And then the dub, the closing of the semilunar valves, comes essentially in the midst of the T wave. The midst of the T wave. All right, now what if you have some sort of ischemic heart disease? That is to say, what if you've had a heart attack? On a single lead EKG, the most surefire sign of a person who's had a heart attack is this dip, this what's called a slurring of the recovery from the S to the T. That's a sign of ischemia. So you have this could also be caused by blockage of one of the coronary arteries. That could cause that too. But usually this is a sign of tissue in the heart that's dead. So your recovery from depolarization to repolarization tends to kind of slur, like you're dragging your foot or something like that. Other signs of a heart attack is there are blood signals essentially that'll tell you if you've had a heart attack. The biggest is cardiac troponin. Cardiac troponin. And then that's kind of a short term, although troponin can stay in the blood. Troponin is a big protein, doesn't break down very quickly. But the heart then will start to release other proteins later on, and creatine phosphate, and the heart-specific isozyme of lactate dehydrogenase. You'll see that usually later on. So if someone comes and they've had a heart attack and it's been 24 hours, their troponin levels may have gone down, but these essentially will now be higher. So there's blood markers you could use for a heart attack. And if you're doing a 12 lead, usually what you'll see is oh, there it is. CV5, see what we have with the QRS? That look normal? Everybody go like this. No, that's not normal. You got this, I mean, look at that. Good gravy. You got this big, huge elevation of the ST wave. That's the so-called ST wave elevated myocardial infarction, or a STEMI. A STEMI. That's the most common type of heart attack, is a STEMI. If your damage doesn't go through the whole wall, then you don't get this. It's called a non-STEMI. That's less severe than a STEMI. All right, let's talk a bit about arrhythmias. So arrhythmias are disturbance in the rate or the rhythm or the site of origin or the conduction of cardiac electrical activity. It's a disruption or disturbance in the rate, the rhythm, the site of origin, or the conduction of the cardiac electrical activity. That's an arrhythmia. Arrhythmias can be completely asymptomatic, but they might be picked up on an EKG. They might present with so-called palpitations. Palpitations. Someone says they have palpitations. That typically means they're aware of their heartbeat. The heart's beating too hard or too fast, or it's skipping a beat, or it's fluttering. That will usually be something the patient will describe to you. And you folks are going to be PTs and OTs. You have a person with a bad heart who's recovering from, say, a joint replacement. It's not uncommon for those folks to overdo it. And they'll come to your office and they're, oh, I can feel my heart is pounding. Pay attention to that, because they might be having an episode. So first and foremost thing, you have them rest. You have them sit down and rest, and then you say, you're just going to rest, then I'm going to deal with you. You just rest, just chill, find your quiet place, and then we'll deal with you. Okay, first two main types of arrhythmias: heart beats too quickly, heart beats too slowly. Heart beats too quickly, heart beats too slowly. Too slowly is slower than 60 beats a minute. That's bradycardia. Too quickly, if you're beating faster than 100 beats per minute, that's tachycardia. And there's lots of reasons why the heart might beat too slowly or too quickly. Little bit about these two types of arrhythmias. If you have a supraventricular arrhythmia, the heart's beating too fast, the QRS wave will be squished together. It'll be very, 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 very narrow. If it's ventricular, the QRS will be pulled apart. It'll be widened. That's just a little sign so you know, essentially. So just looking at this one here, what do you think there? Is that supra or is that ventricular? Oh, come on, somebody guess. You're not going to go to hell if you get it wrong. Just tell me, supra or ventricular? Supra, yeah, it's pushed together. That'd be a supraventricular tachycardia. And then a flutter simply refers to beats that are in the 200 to 300 per minute range. And then fibrillation means there's no coordination between the top and the bottom of the heart. This is life-threatening. This is life-threatening. All right, we are out of time. And blocks, please read about blocks. And yeah, so read through the rest of that. When we come back, we're going to start on blood pressure medicine. Have a great break, everybody. Please don't forget everything I've told you. Okay, gang. Hey, gang, play well, okay? And if you guys have any questions, just email them to me, okay?
Okay, thank you.
All right, you guys don't get sunburned, okay?
Okay.
Sounds
Wear
good.
sunscreen, very important. Okay, bye.